I'm Dr. Kakar. I was formerly Director Professor of Surgery in Malanazad Medical College. Retired in 2012 and has been associated with private hospitals which have got DNB courses. It's always a pleasure to interact with the young friends like you who are in the initial stages of surgical career. Today you are residents. Sure enough, another few years, 2, 3, 4 years, you will be consultant and you will be sitting where I am sitting today. We are going to discuss a very common problem, a clinical evaluation of a patient with a goiter. Good old days when these fancy investigations were not available, radiological, biochemical, or nuclear medicine facilities were not available. The diagnosis used to be based on the clinical assessment of a patient. And in the clinical assessment of a patient who comes with a goiter, most of the diagnosis was based on history taking. Goiter was visible. The question was this goiter euthyroid? Was this goiter hyperthyroid? Did this goiter have any associated pressure effects? What could be the cause of the goiter? Was all based on a history taking supplemented with physical examination. When a patient comes to you or brought to you with a goiter, not only you take a history from a patient himself or herself, there are times when you feel it is better to ask the relatives, or in case of children, ask the parents about this history. There are many things which a person himself may not be able to explain to you or answer you, which you can understand from patients' relatives, especially their behavior, especially their attitude, especially their how they have been doing the last few months or years, especially in children. You want to find out whether the patient got features of hyperthyroidism. Yes, weight loss in spite of good appetite, poor sleep, nervousness. They are very classical manifestation of primary hyperthyroidism. But in a child, may not be able to explain to you that he has lost a weight. It's common that, a child is growing, so he's losing a weight. Or an elderly person, 60 plus, a lady, who's got a goiter. She's not eating, yet she's losing a weight. She's not taking interest in the surroundings. She was active, she's lately become inactive. She just keeps sitting. But these things can be better appreciated by the patient's relatives. So sometimes you have to ask a history, not only from a patient, but from patient's relatives, especially in hyper and hypothyroidism. Few things. What are the pressure effects? Of course, patient himself or herself has to answer the questions. You can diagnose compression effects by radiological investigation. But should you be doing investigations in all the cases, the fancy investigation? Can't we diagnose some of these conditions on clinical history taking? As a patient, having taken a history, you get to get a vague idea. Is the patient is euthyroid? Is the patient hyperthyroid? As a surgeon, you don't come across a patient who is hypothyroid. They classically go to an endocrinologist or to a physician. When a patient comes in the OPD for evaluation, the evaluation does not begin with examination of neck. Examination begins with the moment patient walks inside the OPD. How the patient's overall appearance is. What is the attitude? Is he fidgety? Is he restless? Is he looking all sides? He can't sit at one place. And if he's sitting with you on a chair, is he fidgeting with the pen or the stethoscope or the pencil on the table? Or you notice that he has got involuntary movements of the hands. Or you look at his dress, or in winter, if a person comes to you, you wearing a jacket or sweaters, or a woman is wearing a shawl and a thick sweater, but this person is not wearing any woolens at all, and yet she's sweating. That gives a clue that the patient has got features of hyperthyroidism. You don't need a fancy investigation to diagnose that this patient has got a hyperthyroidism. All this can be assessed as the patient walks inside the OPD. Before we come to the examination, straight to the neck, having done the general physical examination, the important component in a patient with a goiter is examination of radial pulse. One must, I repeat, one must spend 1 full minute to examine or to palpate the radial pulse. Palpating only for 10 seconds or 15 seconds will never give you a correct diagnosis. Irregular pulse or a collapsing pulse or a irregular pulse or a missing beat can only be picked up if you have examined a radial pulse for a minimum of 1 minute by watch. And mind you, in a patient with a goiter, whether it is a primary hyperthyroidism or it is a secondary hyperthyroidism, examination of pulse gives you a lot of clue in establishing or coming to a diagnosis whether the patient is hyperthyroid or not. A missing pulse with doubtful signs of hyperthyroidism in a person with a multinodular goiter is very suggestive that the person has got a secondary hyperthyroidism, which is manifesting in the form of a cardiovascular manifestation. The next question is this swelling thyroid? Are you sure the swelling in the neck is a thyroid? The classical feature to say that the swelling in that patient who has come to you as a goiter is, ask the patient to swallow. If the swelling moves up with swallowing, 99% you are right that it is a goiter. Though you can have a goiter which does not move with the swallowing, especially if it is a recurrent goiter. It is a malignant goiter which is infiltrated into surrounding structures. It is anaplastic carcinoma. But 9 out of 10, the first thing that one has to do is to look for movement of this swelling on swallowing. Presence is nearly in the absence of any past history of surgery diagnostic of it to be a goiter. It also gives a clue. Can you see the whole goiter, or can you see the lower limit of the goiter or not? You don't need straight away a palpation. If you can see the lower limit of a goiter, obviously patient doesn't have a retrosternal extension, and you don't have to do an investigation or detailed physical examination to exclude that a patient doesn't have a retrosternal extension. For palpation, it can be done from the front, but the best is to stand at the back of the patient, gently, passively flex the muscle so that the muscles and the deep fascia gets relaxed and it becomes easy to palpate the thyroid gland. This is a sternocleidomastoid, and you palpate one lobe of a thyroid to looking for consistency, firmness, extent. Palpate for the other side of the other lobe of the thyroid and ask a patient to swallow. To get to the lower limit of a thyroid swelling, which is very, very important, especially if you've got a person with a multinodular goiter. Having done the palpation of a thyroid from the back, you come back to the front. Sit in front of a patient nearly at the same level and look for the pressure effects of the thyroid. One of the important things to look for is what's happened to this windpipe, that is the trachea. This is the thyroid cartilage, and this is the trachea. We know the thyroid gland is trapped on either side of the trachea, and you want to know whether this thyroid, if one lobe is big compared to the other, is it displacing a thyroid or not? And that, especially if a patient has got a bilobar enlargement or one lobe is very big, you want to find out whether the trachea has been, which is a midline structure here, whether this enlarged lobe has pushed the trachea to the contralateral side or not, which is important from a surgical point of view, because when you're operating, you would like to know where the trachea is. And the way to find out is trace the Apple's Adam downwards, cross the hyoid bone, feel the trachea, and in the suprasternal notch, insinuate your finger between the anterior border of the sternocleidomastoid on one side and the trachea, and anterior border of the sternocleidomastoid and the trachea on the other side, and notice, is the trachea in the midline or not.